Welcome to this video on endotracheal tubes. Endotracheal tubes, or ETTs, are flexible tubes inserted into the trachea through the mouth or nose. They maintain a patent airway, allow oxygen delivery and mechanical ventilation, and are essential in the ICU, emergency settings, and during anesthesia. The indications for ETTs include respiratory failure, airway obstruction, general anesthesia, and cardiac arrest. They are also used for unconscious patients with aspiration risk and those suffering from severe trauma. An ETT has three main sections: distal, central, and proximal. Key parts include the beveled tip, Murphy's eye, and cuff on the distal end. The central section has the vocal cord guide and radio-opaque line. The proximal end features a 15 mm connector, self-sealing valve, and pilot balloon. There are several types of ETTs. Cuffed tubes create a seal for adults. Uncuffed tubes are used in pediatrics to reduce airway trauma. Performed tubes are pre-bent for specific surgical fields. Double lumen tubes allow independent lung ventilation during thoracic surgery. Reinforced tubes contain a metal spiral to prevent kinking. Here are visual examples of the cuffed, uncuffed, performed, double lumen, and reinforced ETTs. Proper ETT size selection is crucial to prevent trauma and ensure proper ventilation. Adult sizes range from 8.0 to 8.5 millimeters for males and 7.0 to 7.5 millimeters for females. The pediatric size formula is tube size in millimeters equals age divided by 4 plus 4. Intubation secures an airway for mechanical ventilation or anesthesia. Essential equipment includes a laryngoscope, ETT, stylet, syringe for cuff inflation, suction apparatus, bag valve mask, stethoscope, and a capnography monitor. Key steps in assisting with intubation include preparing equipment, positioning the patient in a sniffing position, assisting with laryngoscopy, and providing the ETT. After insertion, inflate the cuff, connect the ventilator or ambu bag, and continuously monitor vital signs. Cough pressure measurement assesses airway clearance and helps predict successful extubation. It also ensures proper airway sealing. Normal pressure is 20 to 30 centimeters hydrogen oxide, measured with a cuff manometer. High pressure indicates tracheal injury, while low pressure suggests air leak and aspiration risk. ETT placement confirmation relies on clinical observation and auscultation. Clinical signs include chest rise, condensation in the tube, and improved oxygen saturation. Auscultation checks for equal breath sounds in both lungs and no gurgling in the epigastric area. Further confirmation methods include capnography, which is the most reliable, showing continuous carbon dioxide waveforms for tracheal placement. A chest X-ray confirms the final position, ideally 2 to 5 centimeters above the carina. Ultrasound can also quickly differentiate tracheal from esophageal intubation. ETT fixation secures the airway against dislodgement and pressure injuries. Key methods include adhesive tape, commercial tube holders, or surgical sutures. The suctioning procedure includes pre-oxygenating, inserting the catheter gently until resistance, and withdrawing slightly. Apply suction only upon withdrawal, rotating the catheter, keeping duration under 15 seconds. Safety measures involve specific pressure limits for different age groups, and using a catheter no larger than half the ETT's internal diameter. Thank you for watching this video.